Welcome to tube thoracotomy placement, also known as chest tube placement. The limitations of this presentation are that it is for non-emergency basic chest tube placement for patients with a pneumothorax that are not on a ventilator. We will also discuss normal water seal drainage kits and not go into some of the sophisticated ones that are used in today's intensive care units. As with any procedure, you want to start off with a consent informing both the patient and family members when this is possible. This is determined by your facility and the emergence of the condition. As with any procedure, equipment set up in an orderly fashion prior to starting is of utmost importance. If this is possible with a non-emergency procedure, it is recommended for chest tubes as this helps to relieve the anxiety of the provider. In selecting your chest tube sizes, in an adult non-traumatic pneumothorax, it is suggested a 24 to 32 French size is used. In an adult traumatic chest tube placement with a possible hemothorax, it is recommended a larger 36 to 40 French tube is used. A chest tube kit comes in a prepared package, or it is made by your central supply department. But in a pinch, a minimum selection of supplies is required, which includes your chest tube, a number 10 scalpel, a medium Kelly forceps, O-suture, petroleum gauze and 4x4 dressings, provider barrier protection, and of course the patient's barrier protection, the sterile drapes, local anesthesia, and an aseptic solution. You also want to make sure you set up the sterile water seal drainage system, such as the commercially available Pleurovac system, which come in a variety of models. This is important that it is set up prior to beginning the procedure, so if any difficulties are encountered in the understanding of the equipment, this is addressed prior to when it is actually needed. Technique. When performing a procedure on a patient's chest and lungs, oxygen would normally be administered at a flow rate that is determined by their clinical condition. You want to make sure that full barrier precautions are used. You want to wash your hands, use protective safety glasses or a mask shield combination. Using a mask helps prevent fluid on your face. You want to make sure you use a sterile gown, sterile gloves, and if possible, hat and shoe covers for your protection of your clothing. You want to make sure the equipment is set up in the order that is going to be used. This helps you to know that everything is there prior to starting the procedure, and it helps make the flow of the procedure go smoother. Patient positioning is of paramount importance in most procedures, and with a tube thoracostomy, you want to elevate the bed approximately 30 degrees and rotate the patient slightly elevated on the side that it is being inserted on. A pillow works good for this. You also want to place the arm over the head on the side that it is being inserted. In selecting your location, you want to use the 4th or 5th intercostal space at the anterior axillary line at the level of the nipple. This site corresponds to the anterior border of the latissimus dorsi muscle, the lateral border of the pectoralis major, the apex just below the axillary, and a line horizontal to the nipple. This area is also known as the triangle of safety. It helps prevent the inadvertent insertion of the chest tube in an organ where you don't want it. Verify before placement the side that the tube is to go on with the physical findings and the x-ray, and they both must correlate. Prep the area with an aseptic solution of your choice, and betadine is usually used for this. You want to drape the area with sterile towels or a large field drape, giving yourself plenty of room to work. Of course, if this was a life-threatening emergency, you would not be doing this. Basic steps. In placing the chest tube, you want to make sure the patient is comfortable and you as the provider are also comfortable. You want to administer analgesia, which most people use a 1% lidocaine solution with a small bore 25 gauge needle by making a wheel in the skin and subcutaneous tissue at the previous identified landmark. Then going through this wheel using a larger needle, such as a 22 gauge, infiltrate into the muscle, the periosteum, and the parietal pleura. Once entering through the parietal pleura, you would aspirate, and in some instances you may get a large backfill of a dark colored fluid. If you do get this, it should most likely be sent for a specimen depending on your local protocol. Your incision, the incision being made with a number 10 blade, needs to be at least a 3 to 4 centimeter transverse incision through the skin and subcutaneous tissue on top of the 5th rib. Using a large Kelly clamp, bluntly dissect over the rib through the subcutaneous tissue and through the intercostal muscles through the parietal pleura. Taking a medium Kelly, you then blunt dissect, going down over top of the rib. At this point, you could prepare your chest tube by clamping off the open end and having it in position. You then come in through that hole with your large Kelly, blunt dissecting, and pop down through into your lung, opening your Kelly up to make a large hole, and then withdraw it. At this point, if you're using a small evacuation tube, you could just then insert it. If you're using a larger one, you actually need to insert your finger into the track and make sure that there's no pleural adhesions. You can grab the fenestrated or the end of the tube with the holes in it with your Kelly, and then following the same tract, you insert your chest tube, making sure you're following the track over the rib, punching into the pleural cavity. Opening up your Kelly, you would then feed your chest tube into the pleural space until all the holes of the tube are within the pleural space. Remove the Kelly from the chest, being careful not to remove the chest tube also. Once inserted, you would make note of the number. At this point in time, if this was a life-threatening emergency or you don't have your water seal set up, you could take a device like the Heimlich valve and insert that into the end of your chest tube, releasing your clamp. Fluid will come out of it and it will be a mess, but at least that's going to relieve your tension pneumothorax. If you're using the water seal device, you would take the sterile end, removing the cap, and placing that inside your chest tube. You could then release your clamp and it's going to immediately start draining. In adjusting your suction, the suction line comes in. This gives you your centimeters of water, and that's usually preset at a -20. That creates your vacuum. After inserting your chest tube and making sure it's connected to your water suction or your one-way valve, it needs to be secured in place. This is done by a variety of ways, but regardless of how you end up doing this, you want to make sure you're using a large suture such as an O-silk. In placing your stitches, a simple stitch on either side of the tube works the best, taking great care that you do not suture the tube into the person. That is not good form. After securing your knot and removing your needle, your excess suture material should be wrapped around your tube. This is also then secured, helping to hold your tube in place. This should be repeated on the other side. Now, to aid in removing your tube, if you take a additional suture and put a mattress stitch in, this will help whoever removes it significantly. After placing your mattress suture, just grab the end of your suture and you just want to put in a overhand knot at the end of your suture. You're not going to secure this suture in place.
I like to throw 2 of them just to be safe that it doesn't come untied. There. This then gets incorporated into your dressing for later removal. For your dressing, you're going to use a Vaseline or a petroleum impregnated gauze by opening it up and wrapping it around the tube to get a seal. So that previous mattress suture, you just put that in there, and that gets incorporated right into the dressing. Wrap that around the tube, that helps get your seal. Taking a fenestrated 4x4, if you don't have a pre-made one, this can be made by just cutting a Y into your 4x4. This is placed around the tube, and then other dressings or 4x4s are taken and folded into a roll, which can be placed underneath the tube to help secure it and make it more comfortable to decrease the angle. At this point, using a large amount of the widest tape you have available, this is used to secure the tube to the actual patient. If you have benzoin, that can be placed on the skin, and please try not to place your tape across the nipple. After having the majority of the dressing secured, you would take one more piece, putting it a little further south of your insertion site, putting it around the tube, securing it to itself. This just gives that an extra layer of security. So if it's being pulled on the tube, it's taking the stress at this piece of tape and not actually at the suture and the insertion site. You should also secure the connection between the chest tube and your drainage site by putting another large piece of tape over here. This is just a safety item in case it would accidentally get pulled. Some people actually use a wire tie type of product to secure this with a tightening device so it does not remove. As an emergency, as we had mentioned, we can use a Heimlich valve as a one-way valve until a chest tube water seal drainage system can be set up. The chest tube drainage systems vary by manufacturer, and they can be sometimes complex to hook up. So we're just going over the basics because you have to be familiar with the equipment at your location. Once you open it up, in the operating room, of course, it's sterile. In the emergency room, you want to pay attention to the tips to make sure their sterile caps stay on. You first have to institute water into the seal. This particular brand is extremely convenient. It comes with a pre-filled ampule that you then insert into the water device. Breaking off the cap, you then insert this and fill the entire water chamber, which is down here. There's actually a coloring in here. It turns blue and the bubble comes up. So it's the entire container and it fills up to the 0. That gives you your water seal. If you're using or refilling it for some reason, you can also take a syringe, pulling the plunger out, keeping this sterile. You can then insert that and use this as a funnel. So then you have a sterile funnel to instill your water into the seal. That's a little trick if you're in a tight situation. After the water seal is obtained, you then place it to suction, and normally the suction is turned to 80 or higher because the water seal or the vacuum is not controlled by the wall suction, it's controlled by the water inside the device. This particular device, you can actually set it. The normal is a -20, but there is a wheel that you can turn back here to select whatever water seal you want, depending on your patient's requirements. So in order to remove your chest tube, you remove your dressing first. I actually prefer placing a Heimlich valve within the chest tube after removing the water seal. That slows things down. You don't have to rush as much. If you don't have the Heimlich valve available, you can just cross clamp the chest tube. Then taking scissors, you would cut the previous sutures, being careful not to cut the mattress suture that you had placed. Cut the end of the knot off your mattress suture, and then get ready to tie it. Your assistant then is going to come in and actually remove the tube, but what what you're going to do is make your throws, snug it down, and then your assistant's going to pull the tube out. And how you do that is some people have the person remove the tube on full inspiration, some do expiration, some don't worry about it. I'm a full inspiration person because if they gasp, which they will, you take in a breath. So if you already have a full breath, you can't take in more. So the commands to the patient, if they're able to follow them, would be take in a full breath, hold it, go ahead, and they pull the chest tube out. As soon as it comes out, you secure it, your mattress suture, and that plugs your hole. You then tie it off, and then put another dressing over top of it using your petroleum or Vaseline gauze with the dressing. At that point in time, you'd re-examine the patient with lung sounds and an additional chest x-ray.